I've been staring at this blank deposition document for 6 weeks now. The attorney representing Thomas Weir's estate keeps calling, and now they've filed a formal subpoena requiring my testimony and written statement within 7 days. The problem is, I don't know how to explain under oath what happened between March 8th and March 17th without destroying what's left of my professional reputation or sounding completely insane. But they want a statement, so here it is. My name is Dr. Jonathan Pierce. I'm a board-certified psychiatrist with 16 years of clinical experience. I skipped 2 grades in school and entered college at 16, which is why I completed my residency at Johns Hopkins at an age younger than most. I did a fellowship in forensic psychiatry at UCLA and spent the last decade working at Lakeside Psychiatric Institute in Portland, Oregon. Before this case, I had evaluated over 2,000 patients, testified in 47 court proceedings as an expert witness, and published 12 peer-reviewed articles on psychotic disorders and dissociative conditions. I'm telling you this because I need you to understand that I'm not some inexperienced resident who panics at the first unusual presentation. I've assessed patients who believed they were Jesus Christ, Napoleon, and victims of elaborate CIA mind control operations. I've worked with dissociative identity disorder, schizophrenia, delusional parasitosis, and every variation of psychotic break you can imagine. I thought I'd developed a pretty reliable bullshit detector over the years. I was wrong. The case I'm about to describe is why I resigned from Lakeside on April 2nd. It's why I've relocated to a different state, why I no longer practice psychiatry, and why I now work as a consultant for pharmaceutical companies, evaluating drug trials from the safety of an office where I never have to see patients face to face. If that sounds like I'm running away, well, you'll understand why by the end of this. It started on March 8th, a Tuesday. I was on call for psychiatric admissions when the ER contacted me about a patient they were holding on a 72-hour involuntary commitment. The patient was a 29-year-old male named Thomas Weir who had been brought in by ambulance after an apparent suicide attempt. He'd been found by his roommate sitting in his car in their closed garage with the engine running. Suicide evaluations are routine in psychiatric practice. I've done hundreds of them. The standard protocol is straightforward: assess immediate risk, evaluate mental status, determine appropriate level of care, and develop a treatment plan. I went down to the ER around 2:30 in the afternoon expecting a standard case. The ER physician, Dr. Rachel Morrison, met me outside the examination room. "John, this one's a bit unusual," she said. "Medically, he's fine. Carbon monoxide levels were elevated, but not critical. His roommate found him pretty quickly. But his mental status exam is strange." "Strange how?" I asked. "He's calm, coherent, and fully oriented. No evidence of psychosis, no disorganized thinking." When I asked why he tried to kill himself, he said he needed to stop remembering things that weren't his memories. That got my attention. Dissociative symptoms? Maybe, but he's very specific about what he means. You should talk to him yourself. I reviewed his chart before going in. Thomas Weir, 29 years old, employed as a data analyst for a tech company. No prior psychiatric history, no significant medical history, no medications, no known drug use. His toxicology screen was negative for everything except a small amount of alcohol. His vital signs were stable. On paper, he looked like a healthy young professional who'd made an impulsive decision. I entered the examination room and found Thomas sitting on the bed, staring at his hands. He was average height, thin, with dark hair and the kind of pale complexion you get from spending too much time indoors. When he looked up at me, I was struck by how alert and present he seemed. His eyes were clear, his gaze steady, and there was none of the flat affect or confusion I typically see in patients after suicide attempts. "Mr. Weir, I'm Dr. Pierce. I'm a psychiatrist, and I'm here to talk with you about what happened today." "I know who you are," he said quietly. "You're the forensic psychiatrist. You worked on the Garrett case last year, the man who killed his neighbor and claimed he was defending himself from a demon." This wasn't particularly unusual. Lakeside wasn't a huge facility, and my court testimony sometimes made the local news. "That's right. Can you tell me what happened today? Why did your roommate find you in the garage with your car running?" Thomas took a deep breath. "Because I can't make it stop, and I thought if I died, maybe it would end. What can't you make stop? The memories. Except they're not my memories. They're someone else's, and they won't leave me alone. I pulled out my notepad. This sounded like a classic dissociative presentation, possibly the early stages of a dissociative identity disorder or some form of depersonalization. When did this start? About 6 weeks ago, late January. I woke up one morning and there were these fragments, little pieces of memory that didn't belong to me. At first I thought they were dreams, but they were too detailed, too specific, and they kept getting stronger. Can you describe one of these memories for me? Thomas looked directly at me, and something in his expression made me uncomfortable in a way I couldn't immediately identify. I remember your 9th birthday party, he said. It was 1983. Your parents rented out the skating rink on Miller Avenue in Sacramento. You fell and hit your chin on the concrete floor, and you needed 4 stitches. Your mother was furious because she'd told you not to skate backward, but you were trying to impress Jennifer Caldwell. I felt my pen slip slightly in my fingers. My 9th birthday had been at that skating rink. I did fall and need stitches. Jennifer Caldwell had been my childhood crush, and I'd been showing off for her when I fell. But these were details that existed nowhere in any public record. I'd never written about this, never discussed it in any published work or interview. Where did you hear that? I asked, keeping my voice professionally neutral even as my heart rate increased. I didn't hear it anywhere. I remember it, just like I remember your first day of medical school at Johns Hopkins. August 1993. You were terrified you'd made a mistake, that you weren't smart enough to make it through. You sat in your car in the parking lot for 20 minutes before going inside, and you called your father from a payphone, even though you knew he was at work and wouldn't answer. You just needed to hear his voice on the answering machine. The examination room suddenly felt very cold. This was not possible. I had told exactly one person about that phone call, my wife, Sarah, during a late-night conversation shortly after we got married. Even my father didn't know I'd called that day. How do you know this? I demanded, abandoning any pretense of clinical detachment. I don't know, Thomas said, and for the first time I heard genuine distress in his voice. I just remember it. The same way I remember my own childhood, my own first day of college. Except these aren't my memories. They're yours. And it's not just you. There are others too. Dozens of them, maybe hundreds. Random people whose lives I'm remembering even though I've never met them. I stood up and walked to the door. I'll be right back. I found Dr. Morrison in the hallway. Rachel, did you discuss my background with the patient before I arrived? She looked confused. What? No. Why would I? Did anyone else in the ER talk to him about me? John, he's been isolated in that room since he arrived. The only people who've seen him are me, 2 nurses, and the paramedics. What's going on? I didn't answer. I went back into the examination room. Thomas was still sitting on the bed, but now there were tears running down his face. I know how this sounds, he said. I know what you're thinking, that I'm psychotic or delusional, or that I somehow researched you and I'm playing some kind of game. But I'm not. I swear to God I'm not. Then explain to me how you know these things. I can't explain it. 6 weeks ago, I was normal. I had my own life, my own memories, and that was it. Then one morning I woke up and there was this overlay. Like someone else's life was bleeding through into mine. At first, it was just fragments. A woman named Patricia, remembering her daughter's piano recital. A man named Robert, remembering his father's funeral. Random moments from random lives. He wiped his eyes with the back of his hand. But then the memories got stronger, more detailed, and I started to recognize them. I work in data analysis, Dr. Pierce. I'm good with patterns. I realized that every person whose memories I was experiencing lived or worked in Portland, so I started trying to track them down. I found Patricia. She works at the library downtown. I found Robert. He's a mechanic at a shop on Burnside. You contacted these people? Yes. I thought if I could understand what was happening, maybe I could make it stop. But when I tried to explain it to them, when I told them about their own memories, their own private moments, they thought I was a stalker. Patricia got a restraining order. Robert threatened to call the police. I sat back down, my mind racing through differential diagnoses. Elaborate delusional system? Shared psychotic disorder somehow involving me? Some kind of savant syndrome combined with exceptional research abilities? None of it fit. "Tell me something else," I said. "Something you couldn't possibly know." Thomas closed his eyes. "Your wife's name is Sarah. You met her during your fellowship in Los Angeles. She was working as a physical therapist at the same hospital. You proposed to her at Point Dume Beach in Malibu on November 12, 2006. It was sunset, and you were so nervous you dropped the ring in the sand and spent 5 minutes looking for it while she laughed." Every word was accurate. Every single detail was correct, down to the date and the location. These were memories I'd shared with no one except Sarah. "You're going to admit me, aren't you?" Thomas asked quietly. "You think I'm insane." "I think you need to be somewhere safe while we figure out what's happening," I said, my professional training overriding my personal shock, "and I think we need to run some tests." I admitted Thomas to our inpatient psychiatric unit that afternoon. I ordered a comprehensive workup: MRI of the brain, EEG, complete metabolic panel, thyroid function, HIV test, syphilis test, heavy metal screening, and a complete neuropsychological battery. I wanted to rule out organic causes: tumors, seizures, infections, toxins, anything that might explain this presentation. On March 10th, given Thomas's continued suicide risk and the ongoing diagnostic uncertainty, I petitioned the court for and received a 14-day certification for involuntary treatment. The judge granted it based on my testimony that Thomas remained gravely disabled and in imminent danger to himself. I also called an emergency consultation with Dr. Michael Chen, our chief of neurology, and Dr. Lisa Hamilton, our neuropsychologist. I needed other professionals to evaluate this case because I was too close to it, too implicated by the content of Thomas's delusions or memories or whatever the hell they were. Dr. Chen examined Thomas the following morning and found nothing abnormal on neurological exam. His reflexes were normal, his cranial nerves intact, his motor and sensory function perfect. The MRI came back showing a completely normal brain, no tumors, no lesions, no abnormalities of any kind. Dr. Hamilton spent 4 hours with Thomas, administering a battery of cognitive tests. Her report stated that Thomas showed superior intelligence, no deficits in memory, attention, or executive function, and no evidence of thought disorder or perceptual disturbances. His reality testing was intact, and he demonstrated full awareness that his condition was abnormal and distressing. "This is the strangest case I've ever seen," Dr. Hamilton told me after completing her evaluation. "He's not psychotic in any traditional sense. His thought processes are logical and organized. He has no hallucinations, but he's absolutely convinced he's experiencing other people's memories." "Did he describe any of your memories?" I asked. She nodded slowly. "He told me about a conversation I had with my mother 3 days before she died. A very specific, very private conversation that I've never discussed with anyone." "John, how is he doing this?" I didn't have an answer. Over the next 3 days, Thomas's condition remained stable. He wasn't a danger to himself or others in the controlled environment of the psychiatric unit, but he continued to report experiencing an overwhelming flood of foreign memories. He spent hours writing them down in a journal, trying to catalog and organize them as if they were data he could analyze and understand. On March 11th, I conducted another interview with Thomas in the presence of Dr. Chen and Dr. Hamilton. I wanted witnesses this time, people who could verify what they heard. "Thomas, I'd like to try something," I said. "I'm going to show you photographs of 3 people you've never met. I want you to tell me if you recognize any of them." I had brought photos of 3 Lakeside staff members: Karen Wu from our administrative office, James Patterson, who worked in maintenance, and Dr. Robert Carlisle, one of our psychiatrists who was currently on vacation and hadn't been at the hospital during Thomas's admission. Thomas looked at each photo carefully. When he came to Karen Wu's picture, he paused. "I know her," he said. "Her name is Karen. She's afraid of elevators because she got stuck in one when she was 12 years old. She takes the stairs to her 4th-floor office every day, even though it makes her knees hurt. She's been thinking about asking for an office transfer, but she doesn't want her supervisor to think she's difficult." Dr. Chen and I exchanged glances. "How do you know her name?" I asked. "I don't know her. I remember her. I remember standing at the window of the fourth-floor office, looking down at the parking lot, thinking about the elevator and how much my knees hurt. I left the interview room and called Karen Wu. "Karen, I need to ask you something strange. Are you afraid of elevators?" There was a long pause. "How did you know that? I've never told anyone here about that." "And your office is on the fourth floor?" "Yes, but Dr. Pierce, what? Do you take the stairs?" "Every day. My knees have been bothering me because of it. I've actually been thinking about asking to transfer to a ground floor office." "Dr. Pierce, why are you asking me this? How do you know these things?" "I'm sorry, Karen. I need to get back to an urgent patient situation. I'll explain everything later." I hung up before she could press further. I never did explain. Karen transferred to a different department 2 weeks later, and I heard through colleagues that she'd filed a complaint about the strange call, though it was dropped after my resignation. I looked at Dr. Chen and Dr. Hamilton. He's right. Everything he said about her is accurate. Dr. Chen ran his hand through his hair. "This isn't possible, John. There's no medical explanation for this. None. But it was happening, and it was getting worse. That evening, I received a call at home from the nursing staff. Thomas was becoming increasingly agitated. He was reporting that the memories were coming faster now, overlapping, making it difficult for him to distinguish his own thoughts and experiences from the cascade of foreign recollections flooding his mind. I drove back to the hospital at 9 p.m. I found Thomas in his room, sitting on the floor with his journal scattered around him, pages and pages of handwritten notes. "Dr. Pierce, I can't take this anymore," he said. His eyes were red from crying and his hands were shaking. "It's too much. There are too many of them. I'm losing myself in all these other lives." "We're going to find a way to help you," I said, sitting down on the floor next to him. "How? You can't even explain what's happening. None of your tests show anything wrong, but something is very wrong, and it's getting worse." He picked up one of the pages and handed it to me. "I'm remembering your life too, Dr. Pierce. More and more of it. I remember your residency at Johns Hopkins. I remember your first patient who died, Mr. Stanley Harrison, age 67, cardiac arrest during your second month. You blamed yourself even though everyone told you there was nothing you could have done. I remember your fellowship, your wedding, the miscarriage Sarah had before you had your daughter Emma." My hands clenched involuntarily. Sarah and I had told no one about the miscarriage. It had happened early at 8 weeks, and we'd grieved privately and moved forward. Even our families didn't know. "I remember Emma's 3rd birthday party," Thomas continued, his voice breaking. "The butterfly cake Sarah made, Emma's favorite stuffed elephant that she carried everywhere. The way you felt when you held your daughter and thought about how close you'd come to not having her at all." "Stop," I said quietly. "I can't stop," Thomas shouted. "Don't you understand? I can't make it stop. These aren't my memories, but they're in my head, and they're just as real as my own life, and I don't know who I am anymore." 2 nurses came running at the sound of his raised voice. I stood up and stepped back as they prepared to administer a sedative, but Thomas had already collapsed back onto the floor, sobbing. I left the hospital at midnight and drove home in a daze. Sarah was already asleep. I stood in the doorway of Emma's room and watched my 6-year-old daughter sleeping, clutching her stuffed elephant, and I felt a wave of fear wash over me that I'd never experienced in my professional career. Someone I'd never met before 6 days ago knew the most intimate details of my life. Not public information, not things he could have researched or guessed, but private moments, private thoughts, private grief. And I had no explanation for how it was possible. The next morning, March 12th, I called an emergency meeting with the hospital's ethics committee and the chief medical officer. I explained the case, the test results, and the disturbing accuracy of Thomas's claims about accessing other people's memories. Dr. Stephen Park, our chief medical officer, listened to everything and then asked the question I'd been dreading. "Have you verified any of this beyond your own personal knowledge?" Dr. Chen and Dr. Hamilton have both confirmed that he accurately described private information about them, I said. And I verified his statements about Karen Wu. "But we need more rigorous documentation," Dr. Park said. "We need to test this systematically with multiple subjects and controlled conditions. This could be the most significant case study in psychiatric literature if it's genuine, or it could be an elaborate deception we need to expose. I knew he was right. Over the next 2 days, we conducted a series of controlled experiments. We brought in 15 hospital staff members who had never met Thomas. Each person wrote down 3 specific memories, one from childhood, one from early adulthood, and one from recent years. They sealed these in envelopes and gave them to me without Thomas seeing them. I then brought each person to meet Thomas individually, showed him their photograph, and asked if he experienced any memories associated with them. He got 12 out of 15 correctly. After each session, Dr. Hamilton opened the sealed envelope in the presence of Dr. Chen and myself, and we compared Thomas's verbal statements, which I had recorded and transcribed, to the written memories. 12 of the 15 matches were exact, down to specific details like names, dates, sensory descriptions, and emotional content. For the 3 he didn't recognize, he simply said he had no memories associated with them. The probability of this being chance or deception was statistically negligible. Dr. Hamilton ran the numbers using Bayesian statistics, accounting for the specificity of details like proper names, exact dates, and unique sensory information. She calculated the odds of correctly guessing all 12 memories by chance at less than 1 in 10 to 15, effectively impossible under any conventional probability model. "We need to publish this," Dr. Chen said after reviewing the results. "This is unprecedented. We're documenting something that fundamentally challenges our understanding of memory, consciousness, and individual identity." But I wasn't thinking about publication. I was thinking about Thomas, who was deteriorating rapidly despite our best efforts to help him. The flood of foreign memories was becoming unbearable. He was sleeping only 2 or 3 hours a night, and when he was awake, he was increasingly unable to separate his own identity from the hundreds of lives he was apparently experiencing. On March 14th, Thomas attempted suicide again. He'd somehow obtained a disposable razor that had been smuggled into the unit. Later investigation revealed that a family member visiting another patient had hidden it in a gift basket, bypassing the security screening, which had been focused on larger contraband items. That razor had been traded between patients before reaching Thomas. The incident led to immediate policy changes in our visitor screening protocols. Thomas used it to cut deep into his left wrist in the bathroom of the psychiatric unit. The nursing staff found him within minutes and got him to the ER, where they managed to stop the bleeding and repair the damage. But when I went to see him after the surgery, restrained to the hospital bed with a security guard posted outside his door, he looked at me with complete exhaustion and said, "I can't live like this. I'm not a person anymore. I'm just a container for everyone else's lives." "We're going to find a treatment," I said, though I had no idea what that treatment could be. "We'll try different medications, different therapies." "It won't work," he interrupted. "This isn't a chemical imbalance or a psychological disorder. This is something else, something your medicine can't fix. I can feel it spreading. Every day there are more memories, more lives. Soon there won't be anything left of Thomas Weir. I'll just be fragments of thousands of other people." I had no response to that because I suspected he was right. After 48 hours of medical stabilization and psychiatric observation, Thomas was transferred back to the psychiatric unit on March 16th. The restraints were removed on the recommendation of our consulting psychiatrist, who felt that maintaining dignity and therapeutic alliance was critical, and that continuous nursing observation would be sufficient. This decision would later be identified as a critical error in judgment. That night, I did something I'd never done in my professional career. I went through our hospital database and searched for any similar cases that might have been documented in other psychiatric facilities. I contacted colleagues across the country, asking if they'd ever encountered anything like Thomas's presentation. One response came back from Dr. Patricia Reynolds, a psychiatrist at a hospital in Seattle. She'd evaluated a patient 3 years ago with similar symptoms, a woman who claimed to be experiencing other people's memories. Dr. Reynolds had diagnosed her with a psychotic disorder and treated her with antipsychotic medications. The patient had died by suicide 2 months later. "I wish I'd taken her more seriously," Dr. Reynolds wrote in her email. I thought she was delusional. But reading your description of your patient's symptoms, I'm wondering if I missed something. If this is real, Dr. Pierce, I don't know what it means for our understanding of consciousness and memory. I received 2 other similar responses from psychiatrists who had encountered patients with comparable presentations over the past 5 years. All of the patients had died by suicide within months of their symptoms beginning. None had been successfully treated. The cases had been isolated, scattered across different states and hospital systems. Without a central database for unusual psychiatric presentations, each physician had likely assumed their case was a unique aberration. Only my specific search, looking for these exact symptoms, had connected the pattern. I sat in my office at 2 a.m. on March 17th, staring at these emails, and I realized that I was completely out of my depth. Everything I had learned in medical school, residency, fellowship, and 16 years of practice was useless in the face of Thomas Weir's condition. Modern psychiatry had no framework for understanding what was happening to him, no treatment protocol, no therapeutic approach that could address the fundamental impossibility of what he was experiencing. At 6:45 a.m. that same morning, I received an emergency call. Thomas had been found unresponsive in his hospital bed during the routine morning check. Despite being under nursing observation with checks every 15 minutes, he had somehow managed to save medications from his evening doses over the previous 2 nights. The subsequent investigation revealed a perfect storm of systemic failures. A temporary agency nurse unfamiliar with our protocols, shift changes that created gaps in communication, and Thomas's deliberate deception. He had learned to hold medications under his tongue and expectorate them after the nurse left, a technique he'd apparently researched during his brief access to a tablet computer before the razor incident. The overdose was massive. He'd accumulated approximately 600 milligrams of quetiapine and 40 milligrams of lorazepam. They rushed him to the ICU, but the combination of medications had caused severe respiratory depression and cardiac complications. His heart stopped twice. Even though they managed to resuscitate him, the prolonged oxygen deprivation had caused severe anoxic brain injury. He was placed on life support, and his roommate, listed as his emergency contact, made the decision to withdraw care on March 17th. He was placed on life support, and his roommate, listed as his emergency contact, made the decision to withdraw care after consulting with the medical team and ethics committee. Thomas Weir died at 3:22 p.m. that afternoon. He was 29 years old. The official cause of death was intentional drug overdose with subsequent anoxic brain injury. The psychiatric diagnosis on his chart read psychotic disorder not otherwise specified. I signed off on both, knowing they were inadequate explanations for what had really happened, but having no better alternatives to offer. The hospital administration wanted to move forward with publishing the case study. Dr. Chen and Dr. Hamilton were both enthusiastic about documenting this unprecedented phenomenon, but I refused to participate. I couldn't publish a paper describing a patient who had accurately recalled my most private memories, including things I'd never shared with anyone except my wife. I couldn't expose my personal life to that kind of scrutiny. More importantly, I couldn't contribute to a case study that would frame Thomas's condition as an interesting medical curiosity rather than the devastating nightmare it had been for him. I submitted my resignation from Lakeside Psychiatric Institute on April 2nd, 2 weeks after Thomas's death. In my resignation letter, I cited personal reasons and a desire to pursue other professional opportunities. The truth was that I couldn't continue practicing psychiatry after what I'd witnessed. How could I confidently diagnose psychotic disorders when I'd seen a patient who wasn't psychotic at all, but was experiencing something that our current psychiatric framework couldn't even acknowledge as possible? How could I assure patients and families that we understood the mind when I knew we didn't? Not really, not when it came to the fundamental mysteries of consciousness and memory. I moved to San Diego and took a position with a pharmaceutical company, evaluating clinical trial data for psychiatric medications. I work with numbers and reports now, not patients. I don't have to look into someone's eyes and pretend I understand what's happening in their mind when I've learned that I don't understand anything at all. I still think about Thomas Weir almost every day. I think about his journal, those hundreds of pages of other people's memories written in his handwriting that I reviewed during his treatment. I think about how he described the experience of losing himself, of his own identity dissolving into a flood of foreign recollections. Most of all, I think about the implications of his case. If Thomas could access other people's memories, what does that mean about the nature of memory itself? Are our experiences and recollections somehow stored not just in our individual brains, but in some broader shared space that most of us can't access, but that Thomas somehow could? And if that's true, what other assumptions about consciousness, identity, and the separation between individual minds might be wrong? I don't have answers to these questions. I don't know if anyone does. But I know that after 16 years of practicing psychiatry, after thousands of patient encounters and hundreds of diagnoses, the case that ended my career was the one that I still can't explain. The case of Thomas Weir remains for me the most troubling and humbling experience of my professional life. It taught me that psychiatry, for all its advances and scientific foundation, still operates within a framework of understanding that is fundamentally incomplete. We create diagnostic categories and treatment protocols based on certain assumptions about how the mind works. But what happens when we encounter a case that violates all of those assumptions? I wish I could have helped Thomas. I wish I could have found a way to stop the flood of foreign memories that ultimately drove him to end his life. But I couldn't, and that failure stays with me. I'm a good pharmaceutical consultant. I evaluate data competently and provide useful analyses for drug development. But I'll never practice psychiatry again. Because somewhere in my former hospital's archives sits a journal filled with impossibly accurate memories, written by a patient who knew things he shouldn't have been able to know. And somewhere in that archived journal are entries about my own life, my own memories, transcribed in the handwriting of a stranger who somehow looked into my mind and saw what I'd kept private. That violation of my psychological boundaries, that impossible intrusion into my inner life, is something I'll never fully recover from. The official record lists Thomas Weir as a patient who died by suicide following a psychotic break. But I know the truth. Thomas Weir died because he experienced something that modern psychiatry cannot explain, acknowledge, or treat. He died because he asked for help from a medical system that has no framework for understanding consciousness beyond the individual brain, no way to conceptualize memory as anything other than a private neurological phenomenon. He died because I failed him, because we all failed him, because the entirety of psychiatric medicine failed to provide answers to questions we didn't even know how to ask. I submitted this report not because I think it will satisfy the administration's request for documentation, but because I owe it to Thomas to tell the truth about what happened, even if that truth is incomplete and unsatisfying. The case of Thomas Weir will haunt me for the rest of my life, not just because of its medical impossibility, but because it represents the moment I realized that the field I'd devoted my career to was built on foundations that might be fundamentally inadequate for understanding the full scope of human consciousness. I'm no longer a psychiatrist because I can't practice a profession built on certainty when I've encountered a case that proved how little we actually know.